Our first segment will begin with non-small cell lung cancer molecular testing. How far have we advanced? And I'd like to start by addressing best practices or guidelines in non-small cell lung cancer. Recently, there have been several guidelines developed, and some are yet to be released. I'd like to start with Dr. Sandler and ask him how he uses guidelines. Are these rules that have to be followed, or these recommendations? How do you use them in your practice, Alan?
Well, thanks, David. I think this is a very important question, and I think the guidelines, my approach is, of course, they're guidelines, and there's issues that are unique where we're at. We have the luxury of having all of our patients tested. Everybody with lung cancer gets their tumors tested by the Sequenome system, or now the Iron Torrent. But for practice purposes, what I tell colleagues and what I would do if we didn't have that is I would follow essentially what NCCN has been proposing, is that all patients with non-squamous, non-small cell should be tested regardless of smoking status. And what I test for is EGFR mutation and of course EML-ALK. And I would also actually stretch it a bit to those folks who have squamous cell, but are never smokers or very light former smokers, since they have an incidence of EGFR mutations as well.
Well, Dr. Socinski, in your practice, which patients should be tested in your opinion, and for which gene rearrangements? Again, should it be all patients with non-small cell lung cancer, those with adenocarcinoma? What are your thoughts?
I generally agree with Dr. Sandler. I think we base our testing on histology, and certainly in the non-squamous, and I would agree with Alan, independent of smoking history. In the squames, many of which are heavy smokers, but occasionally you see a squamous carcinoma without a smoking history, and I would test those patients. I think in everyday practice in caring for patients, the actionable molecular findings are EGFR mutations, where we now have a new standard of care, as well as EML4-ALK translocations, in which the data is evolving, but certainly the use of a targeted agent in a targeted population makes a lot of sense. There are a few others that I would think about in practice. ROS1 is an emerging one that we have an actionable drug in crizotinib. And there will be others emerging. At our center, we test for several other findings, BRAF and RET, KRAS, really to identify patients for clinical trials. But in routine practice, we don't yet have a drug for those subsets of patients. But I think in the future we will.
Well, let's move on to the next question, which is, I think, one that practitioners face every day, and that's how much tissue do we actually need to obtain in order to do the molecular testing? Let's have Dr. Langer start off with this.
The more the better, obviously. We increasingly now are relying on core biopsies so that we can make sure we have an adequate specimen. It's interesting in talking to our pathologists, they often like both a biopsy as well as cytology because there are different tests that can be run on each sample. It's not so much the amount of tissue, but the cellularity of the tissue that's obtained, how much tumor is actually in that tissue. If you get a large specimen, but it's mostly fibrotic or necrotic, you'll really be no better off than you would be with a fine needle aspirate. So ideally core biopsies, and this has necessitated fairly frank and lively ongoing discussions with interventional radiology and interventional pulmonology, which have become major players in our interdisciplinary thoracic clinic, and I think that's probably true for most of us.
Well, let's ask Dr. Tsao then about preferred means of obtaining tissues. Obviously, as Dr. Langer mentioned, we might be able to do needle biopsy, which could be a core or a fine needle aspirate where there are multiple passes made, or surgical biopsy. Are there preferred types of biopsies, and also is there anything that's not so good for molecular testing?
So to answer that first, I think the days of FNA should be over for lung cancer because we need tissue for this genetic testing and personalized medicine, obviously, for treatment decisions. So we typically do recommend doing interventional guided, CT guided core biopsies of the lung. The incidence and the risk to the patient is quite minimalized in experienced hands. I think the pneumothorax rate across the country is about 8%, and very often you could just place a pigtail catheter and the patient can go home later that day. So I think it's very reasonable now for lung cancer patients to use core biopsies on the lung. Obviously, we do like doing the primary tumor, but if a patient obviously has a supraclavicular lymph node or something easily accessible, that's very reasonable. Also, endobronchial-guided, ultrasound-guided biopsies are becoming a standard practice nowadays in the United States, and you can get very good tissue sometimes from the mediastinum, now from the lymph nodes. Now, bone biopsies are the one thing that I would say I routinely will never do because you just don't get enough tumor tissue from those patients.
And I think also the decalcification process then interferes with some of the molecular methodology.
I think a point that I'd like to make about that is we need to have good coordination between our modalities doing the biopsy and our pathologist to know that when they do these biopsies, they have adequate cellularity, they get enough specimen at that biopsy setting, and that you're not letting them go without a pathology review to know that you got adequate tissue and adequate cellularity at the time of the biopsy. I think that's important.
And that brings up another point too, which is in patients who have very large recurrent pleural effusions, if you really just can't get to the primary tumor or to a lymph node, sometimes you can actually drain their fluid, spin it down, put it into a cell pellet, and sometimes you can actually get enough cells for molecular testing that way too. So there's lots of different options for these lung cancer patients, and it does require a lot of coordination between all the different disciplines to help the patient the best.
Really depends on the cellularity, because a large fusion with scant cells still be relatively useless.
I know the guidelines that are about to come out from the NSCLC and CAP, College of American Pathology, are going to emphasize using cytologic blocks because that can be, if there are enough cells, as Dr. Langer mentioned, a great way to do molecular testing.